I'm Dr. David Johnson, professor of medicine and chief of gastroenterology at Eastern Virginia Medical School in Norfolk, Virginia. Well, the Nurses' Health Study has been an incredible database by which disease states have been evaluated over prospective decades of recordation by the input of this remarkable ongoing longitudinal study. But most recently, the assessment of gastroesophageal reflux symptoms as it relates to sleep quality has been a very important target, as reported most recently in the article in JAMA. Let me go over with you what the highlights are. First of all, there were approximately 39,000 women they targeted, and as it relates to an age range of 49 to 69, thereabouts, median age was 59. And they looked at, starting in 2005, the recordation of GERD symptoms, and in 2017 added in a sleep questionnaire. It was the Pittsburgh Sleep Quality Index, something that we've used a lot in prospective studies that we've done, in particular in GI diseases and sleep-related abnormalities. And this is a very unique tool because it looks at not only sleep, but next-day function, daytime sleepiness, which is very important, and as it relates here to the implication of GERD and sleep fragmentation. And what they found in this particular study is that even rare symptoms, so patients that had, or nurses that had the symptoms 1 to 3 times a month, the relative risk for association with sleep fragmentation defined by this PSQI abnormality, the Pittsburgh Sleep Quality Index, was 15% greater in those patients. And if you had it once a week, the numbers went up to 30%. And if it was more than once a week, the numbers went up to 53% increased relative risk. So again, the association of GERD and relative perspective of sleep quality was really important. A couple key points here. The Pittsburgh Sleep Quality Index, first of all, is a disease-independent validated instrument. It's not specific to GERD. It's not specific to any diseases. It's cross-validated across 17 different languages. We've used it in a number of our studies. But the assessment here is for next-day function, which I think is the most important. I'm going to give you a clinical program in a second about how you ask your patients. Because the patients were asked in the PSQI about sleep at night and their duration of sleep and their sleep restlessness, but they also ask about daytime somnolence. So what happens when people have sleep fragmentation or sleep intervention, you could probably reflect on this, haven't been on call or had a child cry or a noisy truck goes by or a dog barks, whatever, you wake up. You may or may not remember that the next day, but you've interrupted the sleep efficiency. So sleep hygiene is important when you transition through lateral stages, laterally across the stages of sleep. That's what establishes the circadian rhythm. Typically, it's about 7 hours of restful sleep to do that. But in particular, if you fragment that, you interrupt this. So you more or less sawtooth your way through the night, and that sleep hygiene or sleep efficiency is disrupted. What that means is that also there may be a recall of that. If you wake up and have a cognitive awakening, you could say, sure, I remember having that event. Or you may wake up and have a cognitive awakening and not remember it. That's an amnestic offense, which is normal for some people with sleep. And again, you may also have a sensory arousal. So whether or not it's GERD symptom or you have an auditory arousal or you bump your toe, whatever, these things may be disruptive. So you lose that laterality of smooth transition through sleep. Now come back to the Nurses' Health Study. We're talking about reflux. We're talking about a common disease. 20% or more in the U.S. population have a reported symptoms at least once a week. That number seems to be increasing. We have incident data increasing about 5% a year. A lot of that's tied to obesity. But nonetheless, we find that this is an increasing problem. Now, why is that important? Well, because people need to start to look at sleep. And if it's reflux as a trigger, and your reflux patients ask them about next day function, particularly the next day function question to ask is, how do you feel when you get up? Are you awake and refreshing? Do you have early fatigability? You drag yourself out of bed? You have daytime somnolence? You have loss of concentration, irritability? Those are things we probably may all say we all have, but nonetheless, these are parameters of a look back to the night before for sleep efficiency. And again, if you're not asking those questions, you may miss the whole paradigm of that patient may still have the sleep fragmentation, but just not understand it. Now, when I go into an interval of assessment of this, I ask that, but I ask it now across not just my GERD patients, but across all patients. Why is that? Because sleep is physiologic, important in so many ways. In the patients that have non-alcoholic fatty liver disease, a variety of liver diseases, we're finding an increased association with sleep fragmentation outside of the sleep apneas. The same thing with irritable bowel, functional diseases. If you look at inflammatory bowel disease, 100% of irritable bowel and functional bowel as well as the inflammatory bowel. I ask about this. In inflammatory bowel, when you have sleep fragmentation, you turn on a variety of cytokines which are inflammatory. TNF-alpha, what do we do with irritable bowel? With inflammatory bowel, we use TNF-alpha antagonists. You'd increase CRP, interleukins go up. Again, these are things that are inflammatory and may actually tip somebody over to a pro-inflammatory state now with inflammatory bowel disease. So the other thing that's really important, again, if we come back just to even to a, quote, simple thing like GERD, Ronnie Foss showed this a number of years ago when he did Bernstein testing on patients with fragmented sleep and normal sleep. The sensory thresholds all get lowered. And what happens then, so irrespective if you have a functional symptom or you bump your toe, you have a headache, or you have heartburn from reflux disease, your sensory thresholds are lower. So the same stimulus provides a higher sense of awareness. And again, this is something that ramps up that awareness and again increases the interference with the next day function. We've shown that sleep fragmentation affects a variety of things. We do know that sleep dysfunction affects immune function. Why it is that a lot of people get sick when they travel in between time zones, but there are implications as it relates to also things like obesity. When you have a sleep dysfunction, you have effects on leptin and ghrelin, which are contrary to what you would normally want to have. So your effects on stimulation or suppression of satiety or appetite go reverse. And these are things that I counsel my patients when I talk about reflux, and as well as patients trying to lose weight. These are things that affect cortisol stimulation. Again, we have a significant correlation with type 2 diabetes, cardiovascular diseases, and even mortality statistics associated with sleep fragmentation. So come back to our nurses' health study. What did we learn? Well, a lot of people have reflux. A lot of people have sleep fragmentation. We need to do better as far as asking our patients, do you really have symptoms that may correlate to other things, not just focusing on the reflux, but let's talk about the sleep-related complications potentially. Again, the more we do that, the more we individualize the treatment for the patient. We're not treating him now as a disease state. We're treating him as an individual. That's what we're talking about, personalized medicine. The more we can interact, the more we can engage, the more we ask the right questions, next day function, patients with reflux disease, think about sleep. Again, the better we can do in reforming our best to improve outcomes. So it's time for us all to open our eyes to the value of closing them, even the patients that have reflux disease. We need to talk to them a little bit in a different light, and again, put some perspective on what we can do to mitigate strategies potentially to deal with those symptoms and potentially prevent the consequences now expanding into sleep fragmentation. Hopefully this gives you some guidance next time you have a conversation with your patients, and it will apply across many, many, many disease states, almost everything we do in gastroenterology. Dr. David Johnson, thanks again for listening.